Today, I would like to talk about the way that I think about antipsychotics. So to introduce myself, my name is Jim Lefler. I am a clinical psychiatrist at the Durham VA Medical Center, though what I'm about to say is not related to my clinical practice and is not an endorsement of any type of particular one treatment over another. It is meant for teaching purposes and not for use in the clinical arena. Today I want to talk about how I think about antipsychotics, and what I'd like to do is move from this idea of a symptom-based approach to an approach based on mechanism of action and side effect profile. Much like the way the cardiologist and nephrologist talk about, they don't talk about antihypertensives, and now the cardiologist would say afterload reduction, and the nephrologist would say hypertension or what have you, but they talk about calcium channel blockers, beta blockers, ACE inhibitors, or ARBs. All of those are giving you the mechanism of action, which is more useful in terms of saying, well, person didn't respond to this thiazide, so let's try a calcium channel blocker or a beta blocker, or they have this other comorbidity, such as previous heart attacks, so beta blocker makes sense, or they have diabetes, so an ACE inhibitor or ARB makes sense. In a similar way, I think we can transition from just palliating symptoms that antipsychotics treat to think about the mechanism of action and how we're affecting a person's pharmacology and side effects based on that profile. This idea comes from lectures that I've heard while I was a resident at Duke University Hospital, with great appreciation to Steve Szabo. He's a physician scientist who has a background in serotonin receptors and has done a lot of work in other areas, but first helped me think in the manner in which I'm about to describe. And then Jason Webb, who encouraged us to think about mechanism of action whenever we describe what we're using. So instead of calling it antipsychotic, say like a dopamine blockade agent. So with that preamble, I'll then start and say, first, what I'm talking about is psychosis. And psychosis is a clinical definition that has both positive and negative aspects. Now I'm going to pause whenever I do this to talk about various things, much like if you guys have ever seen Dora the Explorer. I'm going to pause and let you think. So what are the three things that define the positive symptoms? And it's hallucinations, delusions, and disorganized thinking. And the disorganized thinking isn't just what the person is saying, but it's also can be manifested in the way somebody looks. So oftentimes folks will show up and they're unkempt, or they're foul-smelling, or they haven't been taking care of themselves, and it represents a level of disorganization. Or they're kind of failing in life and functionally unable to kind of process the complexities of life. And then there's 5 things that are considered the negative symptoms, and these are alogia, or like not really talking, apathy, not really caring, anhedonia, nothing's enjoyable, apathy, which I already said, I'm sorry, poor attention, and then flat affect, or affective blunting. So that's psychosis. And I don't think a lot of people realize that that's what we mean, and that's what we're treating. And when we say antipsychotic, it's addressing those symptoms. But I want to move from thinking about taking away those symptoms, and really the only symptoms we're good at taking away are these, the positive symptoms. Our ability to affect the negative symptoms is limited in terms of our current pharmacotherapies. Maybe clozapine has some effect, but none of them are robust. I want to move to a mechanism of action kind of idea in terms of the antipsychotics. So I think first step is to think more about antipsychotics as existing along a continuum of different mechanisms of actions. And our current biggest way in which we classify things is FGAs and SGAs. And that stands for first generation and second generation antipsychotics. If I want to move away from first generation and second generation as my words and start thinking about mechanism of action, there's 3 neurotransmitters that really matter, and it's choline, histamine, dopamine, and particularly D2. So it's serotonin, dopamine, choline, and histamine. And we have historical words for the FGAs about what we meant when we had them. And we said low, mid, and high potency. And the potency referred to the amount of D2 blockade. And so our classic low potency anticholinergic and antihistaminergic agent was thorazine, or its other name is chlorpromazine. Now, historically, this agent was used to treat schizophrenia, and it would be on doses of like 200 to a gram. More recently, you're going to see this drug used for nausea on agents of like 25 to 100. Interesting, nausea is kind of treated by these same neurotransmitters, choline, histamine, dopamine, and serotonin. And you block various different regions to get different effects. So think about ondansetron being in this area over here with serotonin, haldol being here with the dopamine, and then thorazine. And then our other agents that we really use in this class are more in the medical arena with metoclopramide. And prochlorpromazine, so Reglan and Compazine, and then and we use those to treat nausea. And then if we move to kind of the D2 agents, thinking about high D2 blockade, classically that's haldol, perfenazine, and then fluphenazine. And there are other drugs in all of the classes that I'm talking about, but these are the ones that I'm most familiar with, and these in particular interest me because they have LAIs associated with, so long-acting injectables. All high-potency D2 blockade. Prolixin in particular has an interesting effect where its LAI has a kind of an onset of action where you actually get a peak effect, kind of more drug than you would in maintenance phase initially. And so a lot of people will use that if this was concentration and this was time. You get initially a lot of concentration and then over time. And so that's where it has a nuanced place in terms of LAI use. So if we're thinking about first generations, we've now broken it up into very different drugs. So like if somebody doesn't respond to haldol, maybe they'll respond to thorazine. And you can see how that's different, right? They're different drugs. This is primarily cholinergic, anticholinergic, antihistaminergic. This is primarily D2 blockade. And so what does that leave us with? It leaves us also with a difference in side effects. And so the side effect that we're thinking about here, if we're thinking about anticholinergic, antihistaminergic, is dry mouth, eyes, retention of urine, constipation, and confusion obviously can cause delirium. So it's kind of, has to be watched in the elderly. And then these drugs also are pretty potent in terms of, because of the anticholinergic and antihistaminergic activity, orthostatic hypotension. Now, they were initially developed as anesthetic agents to put people to sleep, and that's how people first thought they were working. They put people into a coma, and when they came out of the coma, the psychosis was better. It wasn't until later that we figured out we were probably modulating dopamine at the higher doses of like 1 gram of thorazine, and then that improved what we were doing. So that's what's going to happen if you're anticholinergic, right? So you're not going to get as much EPS maybe from those drugs because they actually kind of have they have what we use to treat EPS, though they still can cause tardive dyskinesia. Particularly these I've seen on consults, and patients will have diaphragmatic tardive dyskinesia. So over here, thinking about the side effects in terms of high D2 blockade, kind of fits also in terms of EPS, right? So EPS or neurolepsis or Parkinsonism. And if you recall, Parkinsonism is 3 things, and I'll let you think about what those are. And it's tremor, bradykinesia. Sorry, that got a little small. Bradykinesia and then rigidity as the 3 components of what it means to have Parkinsonism. Neurolepsis meaning splitting of the kind of basal ganglia, and then these can cause TD and akathisia, kind of a sense of internal restlessness, which that also makes sense. It's kind of a basal ganglia movement problem. All of those cause this in terms of these side effects. All right, so that's our first generation. So you can see there's very different drugs. I'm not talking about the mid-potency as much because they're not used as much, and we're just going to move on. But they're very different drugs between low potency and high potency in terms of what they're doing if we think about the mechanism of action. So if we move to the second generations, there's second generations that are essentially D2 agents. And these are the drugs most common that are most first generation like, and that's going to be risperidone or risperidone. It has an active metabolite. It's paliperidone, and both of these have LAIs. Nice to talk about the nuances of that. This has a 3-month LAI, and this does not require oral overlap with its monthly injection. So those are kind of some of the kind of nice nuances. This also has an oral disintegrating tablet. And the side effects here are similar to the side effects here because they have a similar mechanism of action. So they're high D2 blockade. So they're going to cause EPS, TD, and akathisia more so than other drugs. Risperidone does something unique too in terms of side effects. And I'll write that here. And it causes prolactin elevations. And anything that blocks D2 is going to cause some prolactin elevation. But if you look at it, Haldol will cause prolactin elevations. Like if less than 20 is normal prolactin, it gets up to the order of like 20 to 40, 50 maybe. Risperidone can get up from like to 100 and 200. And the reason for that I looked into was that risperidone has 2 active metabolites that affect the tubulo-infundibular system, whereas Haldol only has 1. And so it makes sense that it almost doubles the Haldol's ability to do that. Then one other unique side effect, and the prolactin also is important because there's a class action lawsuit regarding prolactin and risperidone. And then the other one is going to be an alpha activity, and that causes, as you might expect, orthostasis or orthostatic hypotension. So that's risperidone, paliperidone. The most dopamine SGA, so they're most similar to the high potency FGAs. So in my practice, if I meet somebody, they've been on risperidone and they didn't necessarily improve, I'll transition from risperidone maybe more this way on the continuum as opposed to going to Haldol or fluphenazine. Or if I know they did improve, say on risperidone, I don't have access to paliperidone, it may make sense to use an LAI like fluphenazine or perfenazine, which don't require the overlap that risperidone, some people would say Haldol does. So those are those drugs. The other ones that exist in the middle here that are kind of D2 and 5-HTC3 are going to be ziprasidone, which I don't know much about because I don't use it very much. And then we have over here quetiapine, lorazepam, and then olanzapine. Right? As are drugs that have a lot of serotonergic activity, D2 activity, and both Seroquel and olanzapine also have the activity of anticholinergic, antihistaminergic, and that's why they're so sedating. LAIs also exist here with olanzapine, though be aware that you need a 3-hour wait period after giving it because of a rare comatose-like reaction that can occur when giving the LAI version of olanzapine. It has an ODT and an IM form as well. And then, so that's with those drugs. And then if you think about what are their side effects, it's going to be different than these side effects. They don't have as much D2, they don't have as much anticholinergic, but they have some serotonergic activity. And then they also result in quite a bit of metabolic syndrome. And the metabolic syndrome is going to be like lipid dysregulation, glucose intolerance, and obesity. And you can think of olanzapine as causing like 100 pounds of added weight, and quetiapine as being like 50 pounds. Now, that's not on everybody. That's not always going to happen, but those are kind of the relative high-end amounts of weight that people gain. But just be aware, on this side of our spectrum, you are going to gain weight from metabolic syndrome, and more so in these agents than the other agents because of the receptors they're targeting. I want to take a moment to just talk about quetiapine as a special agent, because it's really 3 drugs. Okay, and so it's from like 0 to 150. It's a type of drug. 150 to say 400, it's a certain drug, and then greater than 400 is a certain type of drug. And what's kind of neat is that it is anticholinergic. It is anticholinergic and antihistaminergic at lower doses, and so then it causes sedation. It is serotonergic kind of at this middle range dose, and so that's where people use it for major depressive disorder, PTSD, bipolarity, mood stabilizing agents, and it has a bipolar depression a bipolar depression utility, and then at greater than 400, it's definitely got some antidopaminergic, and so this is like our psychotic level dosing. And so it's actually 3 drugs, and to borrow Stahl's phrase, and he's got an excellent book on neuropharmacology, Baby Bear, Mama Bear, and Papa Bear, so really check that out if you're interested in understanding more. So there, if you think about antipsychotics from a mechanism of action, we've got very different types of drugs resulting in very different types of side effects. And I think that helps understand why patients respond to certain drugs and not others. Now, one other agent that I want to talk about while we're doing this is something that I would say is like a completely different class of drugs, and that is going to be one drug that I haven't brought up yet, and I like to think of this as being a 3rd generation agent. And this 3rd generation agent, so to speak, is Abilify. 3rd generation. And why do I say it's a 3rd generation? Because it's very different than the other ones we already described, and that is that it's D2 antagonist and agonist, right? So that's a new mechanism of action. There's also some other dopamine receptors probably at play. And this was a really neat novel agent. And so also to borrow from Stahl's pharmacology, if we think about a gas tank full of dopamine, and it can be empty or full, and here, if your gas tank, and this is concentration, no, I'm sorry, this is dopamine concentration in the brain, and it's full, you're going to be psychotic. And if it's empty, you're going to have a lot of EPS. So they thought, well, maybe we can just thread the needle and the agonism and antagonism 50-50. Then we'll end up in this sweet spot between the two and be able to treat psychosis and not have EPS. And the other thing is this tends to be weight neutral. Maybe because it's not affecting the serotonin syndrome, that's completely speculative. And I just said that as we were talking. The other thing to be aware of is that this drug causes an interesting combination of side effects on both sides of the line. And you can imagine why, that the world exists kind of in standard deviations, right? So here's our midpoint, and for the majority of people, then they will kind of end up here in this area where they're like 50-50. But then there's going to be people on either end of the standard distribution who will either have more, they will have more antagonism, antagonism, or more agonist activity. And if you have more agonist activity, then you're going to have gambling and hypersexuality. And if you have antagonist activity, you're going to have more akathisia and EPS-like symptoms, right? So it's kind of interesting that it has both types of side effects, but it makes sense given its physiologic kind of profile. All right, so that's the third generation. The last drug I'll just mention, because I think it's unique and novel, is also a primarily serotonergic agent. It does not engage with the dopamine system, or theoretically doesn't, is pimavanserin. And this drug is specifically for folks that have Parkinson's. And that's why you don't get the dopamine activity. So this is also a novel agent in terms of how it works to decrease the psychosis. So that's the way I think about antipsychotics, and I hope that's helpful. And then moving forward, then you can have a more nuanced approach in terms of the way that you treat patients and transition drugs to drugs. Yeah, please feel free to make comments in the section below. I'll try to follow up on those and address those concerns accordingly, and then improve upon the information provided. Thanks so much.